Welcome to the PATH Outcomes Congress for 2017. I'm so excited today. We'll be hearing directly from our service units and our facilities. We'll do a quick introduction, we'll have a few guest speakers, and then we'll jump right into the facility presentations. We are lucky enough to have our panel of experts join us again, and I'll introduce those folks in just a few minutes. My name is Deanne Phillips. I'll be your host today. If you need to chat with me, you can do so in the chat box. You can send the chat privately to me, or you can send it to everyone. It's a great way to send us questions as well that we can address during our Q&A. Also joining me today as our co-host is Carrie Zimmerman. So you can also chat with Carrie. She's been sending some chat messages with some instructions. So keep that chat box open. It's our best way to communicate. And we want to go ahead and start off with just a big thank you to everyone for their participation throughout our 2017 LAN. And especially, we want to thank you knowing and understanding and being sensitive to the time constraints in your day. Thank you for taking the time to join us, to share your thoughts and ideas, to be open and talk about the challenges that you and your facility are facing, and putting what you've learned into practice. Overall, just contributing to our healthcare environment. So thank you so much. As we begin our introductions, I do want to invite you, though, in the chat box, beyond what we've done in the LAN, if there's something that you would like to take just a moment to celebrate your staff, please go ahead and put that into the chat. Share that. Again, our sessions are recorded. We want you to take the opportunity to share any of the great projects you're working on, anything that you want to celebrate a success. As always, our resources are available on our PATH resource page. I will follow up with an email that will link you directly to that. It will have our agenda, we'll have our slides, and we'll have our recording from this presentation towards the end of the week. But our resources are posted there from all of our other webinars. And we have had a few facilities that have asked for the entire suite of the LAN sessions to be included on a CD or a DVD. If that is something that you would be interested in, please reach out either to me or to your PATH partner, and we're happy to supply that. We hope that you can use the LAN sessions within your facilities, make it your own, and spread the great word of the work that everyone is doing. So we're happy to make that available. I'm going to go ahead and turn it over to our Executive Director, Margie Weinbar. She'll be doing our introductions for our speakers today. So Margie, go ahead and
Thank you, Deanne. Good morning. Thank you for joining us today for the wrap-up of the PATH Leadership LAN, the first sessions of our LAN. More importantly, I want to say thank you for joining us over these past several months and taking the ideas that you found useful and applying them in your service units. I don't want to spend very much time today because there are exciting lessons learned that you're going to hear from your colleagues. I've had the opportunity to go through the slides, and I think there's great learning from the engagement that you all have taken part in over these last several months. I do want to thank Deanne and the PATH team for organizing and keeping everything running smoothly and bringing to bear incredible guest speakers and being able to manage all the breakouts and the chats. It's been an amazing experience. I also want to thank CMS and IHS who have supported the PATH activities, and specifically I want to allow a few minutes for who I think of as our CMS and IHS sponsors to have a few minutes to reflect on the activities of the past several months, help set the stage for today's session, and forecast what's next in terms of leadership action networks for the PATH team. And with that, I will turn things over to Jade Perdue, who is the Director of Quality Improvement and Innovations Model Testing at CMS and our very important champion in this work with CMS. So, Jade?
And Jade, if you're dialed in on the phone, everyone is muted when they join, so you may have to dial *6 on your keypad to unmute your phone.
Is that better?
There you are.
All right, sorry about that. I just want to echo Dion and Margie's thanks for your steadfast commitment to improving the healthcare of American Indians and Alaska Natives. We all recognize the difficulty and how hard this work is, and I especially like to thank you for being here today, because we know that there are multiple competing priorities. I'm really proud of the work that the past team has done. They are incredibly dedicated to the aim of achieving a higher quality health care for American Indians and Alaska Natives. We come as partners and very humbly trying to best learn the system and be the best resources that we can possibly be to you. Based on feedback that the past team has received from you and others, the plan for 2018 as far as learning and action networks go related to leadership is to translate these learnings into local actions. So as we hear from presenters from a number of hospitals later today, thinking about how to put what you've learned there directly to use. The 2018 PAS plan will shift from having an organizational level approach to focusing more on individual leaders' personal development and activities to shape organizational culture and support change. Some of the themes that you'll be hearing about are leading others, developing organizational culture, leadership style, awareness and reflection, or even how to bolster your own leadership style, providing patient-centered care in Native American communities. And then I'm very excited to report that you also have opportunities for direct coaching and office hours that can be made available with our faculty experts with years and years of experience that are just waiting to share that with you. I have a request of you for 2018 and an offer. First, my request is that you be bold and boundarylessness and practice boundarylessness. That's something that we do here at CMS, and it's something that drives our quality improvement efforts all across the country. Strategizing your actions for the next year and thinking about how to capitalize on this resource, both the leadership learning and action networks and then the on-sites with the team. Thinking about standardizing standard work and then customizing where it counts. We really believe, based on our experience in working with over 4,000 hospitals and 140,000 clinicians, 1,200 or so communities from all across the country on quality improvement, that standardizing this standard work is what is the key to building capacity at the core, and recognizing that customization is a really important piece of it so that it meets the needs of the communities that you serve. And then finally, practicing some principles and tenets that create meaningful strides in quality for our beneficiaries. And these are things that we try to incorporate in our work all the time. And I think it's something as a leader to be very mindful of, particularly as you're working with very diverse groups across multiple settings, to focus on what's working well and seek to spread it. Know the data, but drill down on the systems. Be inclusive and purposely building your network and influence, and think about the level of influence that you provide for each and every person that you interact with. And then reinforce creating will. I think we find this wherever we go, that healthcare providers are quite taxed. You've heard a lot about creating more joy in work and reducing the clinician burden. And that is a very real thing, and being cognizant of the leadership language that we use and the activities that we have, and continuously being cognizant about creating will for our people will help move us in the right direction. So I just want to thank you again, and then turn things over to Dr. Salvin Harmon.
Thank you, Jade. And Dion, can I get a sound check?
You sound good.
Okay, great, thank you. Well, I want to thank Jade Purdue from CMS, not only for the kind and wonderful comments that she just provided, and for the visionary statements that she is known for, But I want to thank her for her commitment individually, as well as the commitment she represents from CMS, and in particular CMMI and the folks that she works with and for, like Mr. Dennis Wagner, Dr. Paul McGann, for their support through this PATH initiative to bring together this I think of it as a virtual single QIO for all of IHS. You know, obviously it's a partnership, the Partnership to Advance Tribal Health, but you know, I see so much sharing across that network and across the geography of IHS that in many cases it is functioning as a single QIO. And you know, that has a lot to do with the vision of CMS, as well as their willingness to support the concept when proposed from IHS. And so I want to express my gratitude to Jade Purdue and ask that she convey that gratitude to her leadership at CMMI as well. You know, I want to reflect back a little bit on where we were a year ago as this contract was being awarded. You know, a lot of work went into developing the task orders for this contracted work that CMS is paying for, and that we're all benefiting from in IHS. And to see that now coming to fruition, to see that now a year old, and with the level of support that we're receiving from Health Insight and the PATH partners, to see the level of engagement from all of you to regularly attend these Learning and Action Network calls for leadership, to reflect on the world-class contributions that we've received from our speakers, that, you know, again, at no cost to IHS. I mean, this is a value you can't imagine. If you tried to pursue this type of learning in the private sector, you'd be paying thousands of dollars individually to attend these types of learning sessions, and it's being made available to us. And you know, we're able to attend it from our workplace. We don't have to travel to attend it. We can integrate it into our day. We can work around our busy schedules. We can continue to meet the needs of our patients and our coworkers, and still benefit from these opportunities, which I think is absolutely tremendous. You know, I mentioned the great work that Jade Purdue has done, and in supporting us. And you know, I feel like I stand on the shoulders of giants. Jade Purdue is one of those giants. Also, Jonathan Merrill, our acting deputy director for quality, who we'll hear from next. You know, without their vision and their support, I certainly could not do what I do as effectively, and I certainly wouldn't be able to participate in the development of this type of offering for all of you. And certainly, I don't think would see the level of success that we've been able to achieve over this past year, and with this first round of the leadership LAN. It's really exciting to have an outcomes Congress and to be able to hear from those of you that are presenting today on the value that you've derived from these sessions, and some of what you've been able to put in place at your facilities to enhance the leadership of your facilities and to enhance your personal leadership skills. I think this is such a tremendous opportunity for us. And you know, we rarely have had such opportunity to partner on this scale across IHS, and we certainly have not always had this type of relationship with CMS. And so I really think it's the dawn of a brave new world when we can receive this level of support, when we can embrace that support and really put it to work in our facilities and grow from it. I'm excited that all of you are on the call today, and you're going to be sharing your stories with us. Very excited to have our subject matter experts on the line with us as well, to be able to reflect and share some feedback and thoughts on the presentations that they hear. And very excited to now introduce our Acting Deputy Director for Quality, Mr. Jonathan Merrill, to give final comments before we kick off with the presentations.
Hey, thank you, Dr. Salvin Harmon. How's my sound check?
Good sound.
All right. I'll keep my comments brief and get us running ahead on the agenda a few minutes. I want to echo what Dr. Salvin Harmon and Jade and Margie have said. and also to emphasize a very special thank you to the Indian Health Service staff. That we have a challenging role, and we face challenges daily, and we overcome those. And it's really our people in the Indian Health Service that make it a great agency. I think that that our leadership and management challenges that we continue working through on a daily basis are profound. And I think that arming ourselves with new skills and abilities such as come from Michael Pugh, Dr. Thomas Royer, and my friend and mentor Cliff Norman, and the other presenters that we've had throughout the land this year are a fantastic development opportunity for ourselves. You know, the Dr. Deming, W. Edwards Deming, has a few famous quotes, and staying in business is not compulsory. You know, we have to constantly be improving our business and our organizations. You know, one of his quotes, the role of management is to direct the efforts of all components toward the aim of the system. I think a challenge for us in the Indian Health Service many times is learning how to work through the federal bureaucracy in order to keep designing and redesigning our systems and processes to achieve the results that we need to improve the quality of care to our patients and communities. So really focusing on those skills, those abilities, leading through the challenges, and persevering on a daily basis. I want to say a special thank you to the IHS staff. And I want to turn us back quickly onto the agenda and back over to Dion. And thank you all very much.
Thank you, everyone, for your comments. I do want to just take a quick moment and remind folks that we are lucky enough to have rejoining us our 3 subject matter experts, Michael Pugh, Cliff Norman, and Dr. Royer. They will be listening for our presentations, and we'll have a few words to share with us as we are going throughout each of our service units. First off, I want to turn it over to, we're going to hear from Fort Belknap and Thomas Champagne. I think you're going to be speaking. So I'll go ahead and turn it over to you. Please make sure to unmute yourself. And if you're on the phone, you do that with *6 on the computer. You just use that microphone icon. Go ahead, Thomas.
Oh, good morning, everyone.
Good morning. We hear you great.
All righty. Well, hey. Niina stekken, tini tain. Nina na aaninen, na niishit, Danish Karnak. I did a traditional Grovant greeting. Said hello, good morning, all my relatives. I am White Clay or Grovant, and my name is Red Whip. On the beginning slide, you actually seen our tribal flag, and there was representatives of both the Grovant and the Assiniboine that reside here on the Fort Belknap Reservation. And I put that because it's very important that we have representation of who we are serving. It's those our Indian nations. So if we can go to the next slide, please. Oh, yeah, there we go. This is an older picture, and this is the first time I've ever seen both my grandfathers in the same picture. But they're both leaders here at Fort Belknap of the Grovant tribe. The first one is Joseph Nespers. He's towards the back. And then there's Clarence Brocky. He's my other grandpa on my mom's side. That was her father's dad. And then on her mother is Joseph Nespers. But you can see that even back then, you know, there was leadership going on where they were talking with like superintendents from Washington, D.C. So we have representatives of both the Grovant and the Assiniboine here. Next slide, please. This here is, well, first of all, at our governing bodies, we start out with prayer, and prayer is very important. We ask God, Beate, we ask him to come and bless us and help us to serve our people. And so on my father's side, he's Ojibwe from Rocky Boy. And so I've been studying with James Vokelich. And so just a story of background behind this. I coached my son's 6th grade basketball. And at our first practice, I gathered the team around and I asked them, who's the leader? And no hands went up except my son. I then proceeded to tell them that they all are leaders and will continue and contribute to the team in many different ways. I then asked them, who's the best player on the team? They look around at each other, and there's my son. He's in the back, waving his hand, kind of going crazy. And I then proceed again to tell them that they're all the best player on the team. I asked, what do you have to do to be the best player? And again, my son's hand shoots up and he's waving, and I tell him, I know what these guys answered. Then I asked my son, well, what do you have to do to be the best player on the team? And he asked me, you have to prove it. And so the reason why I retold this explanation from James Vokelich at our governance body meeting is that at times we place all the responsibility on one leader's shoulders. This is an influence from the dominant culture. Growing up, my mother, who was raised by her grandma, who was born at the end of the buffalo days, because our people, they're buffalo chasers. We have a relationship with the buffalo. We call them Itanon, which means they give us everything. You know, they gave us housing, food, clothing and stuff. And I was told by her that we did not have chiefs, but we had leaders. And, you know, like from Rocky Boy, there's a Cree chief. He's part Cree and part Ojibwe. In his book, Big Bear, they talk about having 2 different leaders. The Big Bear was the leader of that peace. And then when there was like war or something going on, Wandering Spirit would become like a war chief, and then he would have authority, but they would both kind of share that responsibility. But to this day, my mother repeats these words of my great-grandmother, that we do not have chiefs, but we have leaders. So growing up, I always approached sports and worked with this concept, but didn't have an articulate explanation. And until I heard the following explanation by James, and I'll go ahead and I'll explain it to you, what it means to be a leader as I have perceived it. So James, he talks about these words of the day, and so this particular word was Ogama, and that means a male leader. And there's Ogamakwe, which means a female leader, and we say Nadjan here in Grovant. So he proceeds to tell this story about, like, in Canada, they use Ogamakan and Ogamaukan, and that con on the end, it actually means false or pseudo, because in Canada they recognize that the government, and even down here, they tell us to elect leaders like every 2 or 4 years, you know, and so that goes against the cultural norm of how they would pick leaders, and so that's why they put that con on the end. And so James goes on, he says, to be a leader, it cannot fit just in the political leader definition. There's Ugamak is a term in use for leadership and also means snowshoe. A leader is a consensus builder. A leader is not a dictatorship. They build consensus within their family, within their clan, their community, and then nation. If you look at a snowshoe, there's a number of rawhide strings put together, and they become strong enough to carry a person in incredibly deep snow. And leaders will be like this snowshoe and carry the people in difficult times. You are the one supporting all your people, and you're doing it through the connections you have with all of your other people, your family, your clan, your community, and nation. It just wasn't political leadership that could be obtained. You could become an Ogamawis. You could do it through a number of different ways. Whenever you became an Ogama or an Ogamawis, you would become a first among equals, a first among equals. A radical concept compared to the Euro-government society and even places in Asia. When people first came here from Europe, they, for the first time in their lives, maybe felt liberty. They didn't have a pope, a king, a nobleman, or a priest telling them how to behave, how to pray, how to act, or how to be taxed. A lot of them noticed that for the first time in their lives, they can approach a chief or an Ogama and have a meal with them and their family, and they could be treated as equals and then in turn as relatives. An incredible, important concept to understand liberty, a first among equals. As an Ogama, you are first among equals, you are not more important than your relatives, and everyone is equal, then there are numerous chances for leadership. Not just one person is responsible for all of it. You can have people who are incredibly gifted with hunting, with fishing, with trapping, and with the drum, with ceremony, with healing, with teaching, children, with passing on traditional ways, with harvesting wild rice, and with tapping maple syrup. In all of these ways, a person who is incredibly gifted in one of these areas could become an ogama, a leader in that field. That would be their contribution to society. They'd be doing that for their people. They would hold on to those incredibly important cultural and spiritual practices for all their relatives, and in doing that, they would become the change that they wanted to see in their community. They became the example. They wanted to leave in their community, and that is an incredible important. So they didn't just look to one leader, one pope, one supreme leader to bring change to their nation or to maintain the good life in their nation. They brought it on themselves. They carried that on themselves, and when they did that, they carried it on for all of their relatives. So just explaining, you know, like what leadership is, you know, according to like some of the tribes. So with that, I just wanted to say I hope. Geni Ahan, thank you for listening. Those are just some of the pictures of some of our Groban artifacts.
Thank you very much, Thomas. Thank you. I am going to ask PIMC, Phoenix Indian Memorial Center. If you're on the line, you guys are up next.
You are unmuted. Good morning. This is Cathie Bill. I'm from the Performance Improvement Department here at PIMC. I'm joined here in the room with my colleagues Mike Champagne and Mary Crosby. So we're going to just share some information on a couple of initiatives that we've either put into place or we're getting ready to launch that have arisen from some of the discussions we've had here in ways that we can improve quality and safety here at PIMC. So if you go back to the first slide, there's a picture of our facility. There's a list of our land registrants. Those are people who have participated in the program at one point or another during the past few months. The thing that's unique about PIMC compared to what we saw in the previous presentation is that being an urban Indian center, we serve a community of over 3 million in the metropolitan area, and we also have had service provided here to members of over 300 different tribes. So it's a very, very diverse, even within the native scope, population. So if you go to the next slide then, this refers to what we've entitled the Good Catch Award. There have been discussions that we've had as an organization. How do you reposition the idea of identifying near misses or good catches as something that's seen as a positive, impactful process? Some folks, even when you talk to them, they look at even the term WebCident, which is of course our network for reporting near misses. They even see that term as almost being a negative. So as a department, we were trying to look at ways that we could reframe the concept so that we present it as a positive thing. It's a good thing that you've got something before it becomes an issue that related to harm or to a patient. So the Good Catch Award is an initiative that's rolling out in January. What it is it's a mechanism for staff to commend one another for opportunities where a harm was averted. Technically, it's putting a face on safety. So it's a mechanism to bring forward near misses that will be submitted to the quality division to nominate individuals or a group. So it could even be a department on the scope of the harm that was averted, and preventing a potential error before it reaches a patient. And this supports the whole concept of just culture, which I remember seeing on one of our previous speakers' notes on their introductory slide. Just culture is one in which people feel that they can comfortably bring issues of potential harm or danger forward without feeling fear of any sort of repercussions or blame. And it's focusing on the process. I've just been working through some of the information that was provided throughout IHS, the potential enrollments we've been offered for IHI to do their open school. I just completed the patient safety module. And again, they bring forward very clearly that most of the time when there is an error, even when there is an error, it was due to a systems breakdown. It wasn't due to someone being incompetent or purposely taking action that caused harm. So we're hoping that by using this award mechanism to encourage folks to be vigilant for near misses and to commend one another for bringing those forward, it will help open up to us other opportunities of finding potential areas of harm before they actually become issues related to harm. So then if you move to the next slide, so this is the House report. So this is something that we've actually we've had in place for a couple of years now. What it is it's a 24-hour report. The main purpose is about communication and transparency hospital-wide for leaderships of all levels, inclusive of the quality division. The focus is on ensuring that all patients are receiving safe quality care. The report not only focuses on staffing, census, and patient acuity, but it also focuses on addressing serious reportable events. The serious reportable events are inclusive of the following: patient care management, products and devices, surgical events, and environmental safety. While the House report has become long, it can be shortened and targeted to highlight specific areas. This method of communication ensures high-risk areas are addressed and completed properly. In our organization, we deal often with processes where it's either a high-risk process or it's a low-volume process. Even with our diverse patient population, sometimes we receive patients that are higher in acuity than normal, and it involves processes of care that maybe we don't do frequently. So those are other things that we can report on within that process to make sure that those competencies are highlighted and revisited periodically so those skills are maintained. When there are EOC issues, engineering follows up to let everyone know the work orders have been placed and what's been done to correct concerns noted in the report. Once the report comes out in the morning, the chief and the leaders of the divisions are responsible for following up with frontline leaders to make sure that there's progress and that key people are addressing the issues at hand. Does anyone have any questions?
Any questions for Cathie? And we'll open it up as well to Michael, Cliff, and Dr. Royer. And the chat's a good way to send information as well. Thank you, Jade. Appreciate that.
Hello? Hello?
We can hear you.
Could you email the House report for best practices out?
Sure, we could make that template available, absolutely.
Thank
Cathie,
you.
I can work with you to do that. We can send it out for our registration. So I'll follow up with you and we absolutely can do that.
Absolutely, thank you, Dion.
Thanks. All right, I'm going to turn it over. If you do have additional questions, put them in the chat so that we can address them, thoughts, anything you'd like to add. I am going to turn it over to Callie Raymond. So if you want to take it away, the floor is yours.
Good morning. This is actually Nicole Flom. Sorry for any confusion. Callie entered the room, so I added her in for attendance purposes.
Thank you.
So for our presentation, on the picture, you will see this is the Susan Hospital. The first picture is the front of our hospital when it's snowing, and it looks very similar to that right now because we are getting a lot of snow. You actually wouldn't be able to see the hospital very well. It's almost white out. But anyway, as far as our land participants go, we've had a variety of people from our executive leadership team, our QAPI team, and our nurse administration team. So in the room right now, I have Jackie Yoder, Donna Huber, Sarah Lantis, Debbie Meek, and Callie Raymond just participating today. So you can go to the next slide. The second picture that we have is a picture of our water tower over at the top of the hill. Susan is located at the top of the hill in Rapid City. So that's one of the main things that people look for when they're trying to navigate towards our facility. So that's why we have this picture in there. Our big land takeaway is to not let our weakest links or barriers prevent our forward progress. That's from Dr. Royer's Leadership Competency 2 training. We discussed how easy it is to let barriers prevent forward progress. Our example is a plan for a change of workspace that we had for our registration staff, coders, security, MRTs, and MSAs to try to streamline and improve our patient flow in our outpatient and urgent care clinics. This plan was actually started 6 months ago, but only recently was fully implemented, including we did union notification back in the first week in June. Some of the reasons that we had for the move were to expand our patient care areas on the 3rd floor, which is where we have our outpatient clinic. We wanted patients to be able to register on the same floor as their clinic visit. We wanted data entry to share space with providers to improve coding and possibly revenue. The MSAs were moved to increase scheduling access with more staff available to schedule the patients. Our security staff have also moved to the front entrance to help improve visible security, patient and staff safety, and to help our patients navigate our facility. MRT from room 9 in the urgent care to patient registration areas to help add additional patient exam and additional exam room in our urgent care. Some of the barriers that we had a lot of temporary leadership and acting physicians who weren't able to help sustain progress on this. We have a lot of people that are very resistant to change and get attached to specific workplaces. We also had to wait to get some of the furniture and in for the workstations. And we also had some resistance from providers not wanting unnecessary interruptions from coders. To help overcome these barriers, we now have permanent leadership who are supporting a patient-friendly registration process and increasing space for patient care, along with improved access for our patients. We have supervisory staff. We had them scheduled the first week to help patients navigate the changes. And our new permanent CEO also drafted and provided a letter to patients with an explanation of the changes that we had. Are there any questions?
Great, thank you so much for sharing, Nicole. Was there a question? Did I hear someone speak up?
No, Dion, it's Jade. I didn't have a question, just a comment. I just really want to applaud you for taking on patient flow. That is, you know, not an easy thing to do, and for kind of working through the issues and moving it forward anyway. That's really fantastic leadership. It's so exciting to hear about. Thank you.
Thank you.
And Dion, this is Dr. Royer. I would just say that I'm glad that they pulled that learning out of the presentation. Probably it's one of the most important learnings we shared in the 2 land presentations we did. I would highlight the very important thing that you did. You did many, but really understanding and identifying the barriers and then determining how you can mitigate those barriers and minimize them. And we clearly understand in every change there's resistors, so spending time identifying who they're going to be and then trying to work through them. I think the interim leadership is a major challenge because I think often interims don't take the job seriously because they say we're not permanent, so why do we want to take the risk? And also providers are often resistant to change. So I think you've identified the clear barriers, and I applaud you for working through them and for putting this learning into practice.
Any other comments or questions?
Hi, Dion. It's Dr. Salvin Harmon. I want to echo Dr. Royer's comments, and I want to add that I think this is really a wonderful example of the importance of leadership in supporting change and in being active and visible in change management strategies. You know, identifying the temporary leadership as a barrier, but then also how they overcame that barrier with their permanent leadership, and more than just having permanent leadership, but the engagement of permanent leadership and the willingness for those leaders to go on record with a letter to the patients and to support the change with those that were resistant to it, I think is just such a valuable lesson. And it's so important in this forum for all of us to hear and see that and learn from it. It's a great example of the importance of that leadership engagement for quality improvement.
Okay, let me just see who is able to go next. We have just a request for a quick reorder, so give me just a second here. So if we could hear next from Crown Point. If you want to get ready, I'll get your slide up to present. So Crown Point, you're up next. If you want to unmute yourselves, that would be great. And if you're on the phone only from Crown Point, then all you want to do is *6, and that will allow you to speak up. And let me get your, there we are.
Cool, are you there?
Yep, we hear you loud and clear.
Okay, so this is Cecilia Bilon from Crown Point Service Unit. We have the main hospital and the 2 clinics, about 25 miles south and the other 45 miles northeast. We serve 16 communities covering 200 square miles at a youth population of about 19,500. We're 19-bed facility, and we're direct CMS certified. Next. Next, please. So this is our quality management team, and they're the leaders in really helping and supporting the supervisors and staff with all issues. In addition to our core team, we've had other people attend, our executive members, CEO, Chief Nurse Executive, Director of Public Health, and primarily nursing supervisors, and they were very interested. Next. Next slide, please. Okay, so what we did from our area, from the Navajo area office, with the quality framework and various initiatives, including establishing the consortiums in the different area, including the quality consortium. They have been very supportive in helping us and providing us the direct guidance and providing a lot of leadership, because here we're just, every day we're just kind of, you know, spinning the wheel and just trying to take care of all the issues that come up on a daily basis, and we're not always focused on leadership and the guidance and the support we need to provide. So some of that is coming from our area office, and what they're having us do with all of our trainings is to do a SWOT analysis. So we looked at, with the participants on the leadership webinars, we asked them what were the strengths of the webinars, and they were very impressed with the evidence-based practice information, and the couple of them that were non-direct care, actually, like the PRC supervisor, they were very interested in employee engagement, that section of it. You know, having to communicate with their employees and creating a team and addressing any concerns or issues as a team. One of the weaknesses that they identified was that because we are so short-staffed and with providers and with nursing, many of our nursing supervisors have to be on the floor a good portion of the time. So they were saying, you know, I mean, this really takes away from our patient care, but we have to relook at that and really try to get them to provide more leadership in terms of supervision and managing, and that's one item that I know that we've been talking about lately. Opportunities is that, you know, we again, it's based on the time away, and it's keeping training to an hour, because when we when we did an hour and a half, we really didn't have that much time. They didn't have that much time to debrief and to discuss all of the content that was brought forth and how we could really use it. So that was one of the items that they really thought that there could be more opportunities in. the threat is, again, local leadership buy-in and support is needed. And some of that is being addressed from our Navajo area. There are a lot of initiatives that have been implemented, and one of them is our so next slide, maybe I can get into it there. So with what is going on and the discussion on just culture, our leadership is now looking at the just culture model. We recognize it as a model that could work for us, and we're starting to train people on the model. Everyone has access to the training, and for me, I was trained and I'm a certified just culture trainer. The other thing is we've put more emphasis on risk management issues, and we're getting guidance from the area office on daily quality and safety rounds. Every morning we report any issues, any bad outcomes, and it's been a wonderful tool because we've got all the players in, and we're addressing we haven't had, since we started this a couple weeks ago, we really haven't reported any bad outcomes or any adverse events. Not to say that they don't exist, but not within the last 2 weeks. But it has helped us to identify the risk issues, and looking at some of the things we've really focused in on: environment of care, patient safety, especially in emergency services, where we've addressed emergency services prior to this with UMTALA, but we're constantly refining our processes, and I think it has really brought us forth, okay? And the other thing is training availability, which I spoke of earlier, and all of these training are available in health streams. For the IHI Open School, we've got access from Health Insight from New Mexico, our PATH partners, on giving access to all our staff, especially for the quality and safety modules. Okay. I think that's it. Oh yeah, other comments that we got from the participants is Dr. Royer is very upbeat, and he's transparent and is able to tell it like it is, and that they really appreciated that, and said the presenters were excellent, and that this effort needs to be continued and reinforced to sustain knowledge and skills. Yeah, that's Cecilia from Crown Point.
Thank you, Cecilia. I'll open it up to our SMEs and our guests. Any questions or comments?
This is Michael. Excuse me. This is Michael Pugh. I really like your report on the daily quality and safety and risk management rounds, because that really begins to open up the conversation in the organization about how to change things. And the barrier that you discussed about the frontline supervisors not having a lot of time because they're engaged in the actual care of patients, and that's a real issue in a lot of places. But you continue to work through it, and you think about those things, and I like the way that you've adjusted some of the training and other things to fit their schedules and not your schedule. And I think that's one of the key things about engaging that level of leadership, is to find ways that you can make the trainings and the other things you're trying to support fit into their schedules. So good work on that. And one last comment, I think when you said the threats on the leadership buy-in, when you're pursuing a just culture, you really do have to continue to work with your senior leadership so that they they understand their actions and behaviors, and you can work a long time towards a just culture, but an inadvertent reaction by a senior leader in the wrong direction can upend a lot of things. So that's a correct identification of a potential threat to the just culture. So, but well done.
Thank you.
I will encourage folks to add additional thoughts into the chat, and we can certainly address if we have time. I do want to make sure that we're moving along so that all of our facilities can present their good work. So up next is ACL. You may need to *6.
Hello, am I being heard now?
Yes, great, thank you.
So I'll tell you what, we've been very inspired by the Partnership to Advance Tribal Health, and particularly in Dr. Royer's talk, where we actually had great assistance from the folks to help us get a copy of the talk itself, because we actually had to display it on a monitor where we didn't have Wi-Fi or any internet availability. And we used it as a springboard to discuss several things, including the just culture itself. Dr. Salvin Harmon's talk to me in the prior National Combined Councils in San Diego really inspired me to actually start to implement that in our institution and view all of our areas through the just culture. And so we discussed not only a bit of the just culture, we discussed issues of alignment, institutional alignment, as well as a sense of entitlement was what's one of the hot topics we had. But not only having that, but a mock survey recently brought up our concept of needing a way of managing conflict resolution. And it even inspired more thoughts toward this double loop learning, training for leadership, recognizing there might be an inbred situation within not only Indian Health Services, but other corporate structures, and trying to actually break down these barriers to help with conflict management resolution, achieve better buy-in with our leadership processes. And we're using all of these things, whether it be the mock survey, whether it be the PATH discussions, whether it be all of the input that we're getting, and even having a talk with folks from the Studer Group to help us, because I know that Dr. Royer was part of the CRISTA system. I actually grew up a little bit in the CRISTA system myself, and I know that they actually implement and use Studer Group principles in their management, whether it be leadership rounds, whether it be the high, middle, low matrix to understand how employee behaviors are evaluated. So we're really inspired with a lot of movers in our institution to try to improve our processes on the ground as we move toward a patient-centered medical home through the Joint Commission.
Did you want to go into your additional slides, or is your summary?
I don't think I have any slides. I was just handed the phone and told to talk.
Well, in that case, fantastic, fabulous job. So I'll open it up to the floor to see if there are any thoughts or expressions. Go ahead, folks. Okay. I'll ask Shiprock to get ready, and let me just get your slides up. So if you can please just make sure that you are unmuted, Shiprock, and I will have your presentation presented here in just a moment. Let's just do a quick sound check.
Good morning.
Great, we can hear you perfectly. So, all right,
okay.
And there are your slides.
There we go. So everybody listed on the slide is basically here this morning, except for a couple of people. Go ahead to the next one. So we felt that the sessions were an excellent review of leadership courses at the graduate level, which it was excellent. It was an excellent reinforcement and acknowledgement that what we are doing.
The nursing skills fair will start again at 1300. The nursing skills fair will start again at 1300.
Sorry about that. There's a quality activity. So we have several things going on at the service unit that were in place before the LAN began.
but we had reinforcement that we were on the right track, and we were actually mirroring, sorry, have trouble with that word. We have things like our tour coordinators, our health supervisors give us a report after each shift that they have, where we know during the night what has happened, what events have occurred. We do have an administrator on call schedule, so anything that happens at night during the night in the hospital, we know immediately what's going on and are involved in decision making. We also have a huddle, a Monday morning huddle with all of our execs, which has recently been changed to a daily huddle where, working with Navajo area, we're now sending daily reports to area office about what has happened in the facility, any adverse events or outcomes with patients, any safety issues, environment of care, any our bed status, any limitations of staff, and the impact that it has on the services we provide. We have had a project going on in our emergency room for a couple of years now to decrease our left without being seen rate. So we went from 40% left without being seen to a little under 4% now. So we continue to do performance improvement PDSAs with that to fine tune and continue hacking away at that left without being seen rate. Then the latest version of this is to include the whole entire hospital, inpatient units, ambulatory, and the ER, and broaden the scope and the focus to patient flow, the admission patient flow process. So we expanded that. We do leadership rounds.
I see it.
Every day, every morning, the supervisory clinical nurses have a huddle where they talk about patient flow, they talk about bed status, they talk about risk management issues, they talk about the number of procedures being done in the OR, they discuss environment of care in the OR and our temperatures, humidity. They plan for any beds that need to be reserved for those OR procedures. They talk about pending admissions from the ER. We talk about any issues in the ER that impacts our patient flow, like having a behavioral health patient on hold in the ER for a prolonged period of time. And those reports are shared with all of leadership. And then in the last year, in 2017, we also initiated a bi-weekly review of every websident that we receive with leadership. So the division leaders review the websidents. We talk about the corrective actions. We talk about trends and patterns. We make sure that the division leaders are following up with the employees, the supervisors in their divisions that are involved or impacted by the websidents. So we're making sure that they're all addressed appropriately. And we also have expanded that team to include our safety officer, and we'll expand it even further to include our employee health infection control. We have a good representation of the facility when we do those website reviews.
This is Flavina. Can you hear me?
I can. Go ahead.
Okay. One of the things that we identified in 2017, I think you kind of mentioned earlier, you're talking about organizational culture, you're trying to make the change. And we had huge issues where there was like what you call the horizontal violence, bullying type of activities among staff, and also conflict. How do they deal with conflict? So we had 5 different courses that were offered from May to September. And each course, it was initially started for nursing, but we had other divisions, which include the medical staff, the administrative staff that wanted to be part of it. So these classes had anywhere from 30 to 40 employees. We're going to continue that process of offering this horizontal violence and bullying and just making aware. And it was really interesting. Some of the comments was, I didn't realize I was a bully. My supervisor needs to go to this in service. Now I know how to deal with the conflict. The other thing we've also enhanced was like for leadership courses, We've done that through the ANA. They have some very good online courses. They also, we sent about 5 of our nurse managers to the AONE nurse manager course. And this is kind of giving them a different, I guess, thinking outside the box, not always staying with IHS. And one of the other things is where for 2018, we're really going to focus on the leadership. And then we have a lot of making sure that we have orientation, competency-based orientation. That's it.
We've also been increasing the size of our quality management staff. I think one of the gaps that we have are enough people in the quality management arena to support our direct patient care people. We just have, we're a big facility. We have a large volume of patients, but we didn't have enough data management support or quality management support. So thanks to the leadership team and the CEO, we've increased and added 4 positions this year, which is huge for us to do that. And we would like to thank you for the sessions that were held from LAN. Like I said, it was an excellent review for most of us in the room, if not all, have our masters prepared. So it was a great review. It's a great reminder. And it's good to hear those theories and concepts again. And we did share materials throughout the facility. I know there were some excellent articles that were shared, part of our homework, in the slides, and they were shared with the nursing leaders and my quality services leaders. So thank you very much.
Thank you, Pauline and Lavinia. I really appreciate that. I'll open it up to any of our SMEs. There are some comments and questions in chat for you to address perhaps back in chat. But if there's any additional comments, I do want to give a few seconds to that.
There are questions.
Yeah. So let's address the questions. Let's do that in chat. And again, we'll save the others until the end so that we have plenty of time. I do want to turn it over to Belcourt coming up next. But we will continue to keep our chat open and use that to help communicate and move us forward. So Belcourt, I'm going to ask if you would like to take the floor. Don't forget, you may have to *6 if you're on the phone or unmute on your computer.
Can you hear us?
Yes, sure can.
Okay. So this is Belcourt, and we're named the Quinton Burdick Memorial Healthcare Facility, and this is our location. We're the Turtle Mountain Band of Chippewa Indians, and we have approximately 20,000 active patient membership here at our hospital. And then we can just go to the next slide, and I'm going to turn it over to Ria Dakota. He's our presenter.
So here's all of our participants that were able to get onto the LAN. To the next slide, okay. So what we were able to take away was what some of the qualities would be of the to be an effective leader, how to make all of our decisions based on the patient and to put them into everything that we do. We were able to make some projects that will improve the patient outcomes, and we were able to kind of come up with ways that we'd be able to bring ideas out in the table so we wouldn't take it wrong, and we'd be able to accept constructive criticism. And that was one of the things that we kind of took away, is that sometimes we're not willing to say what we want to because we don't want to hurt feelings or we don't want to hear back from other people, but that's the only way that we're going to be able to make some change. And we also we were able to get quite a bit from the one talk about being accountable and how that's different than being reliable. Next slide. So these are just a few of the projects. The one that I personally worked on was just kind of putting the patient into the center of the room. So we would be able to get more of a program going for those that need shoes. And so it was kind of hard for me to go to that meeting because I thought, you know, what am I going to say? I haven't really had to do that before, but I just put all of my patients that I see have problems and are at risk for amputations, and I just went to the meeting and I put them into the middle of the table and I stuck up for what they needed. And so now we're able to have a diabetic shoe program, and we've put away some money for that. And our patients really love it. They really like it. And it also helps them come in to get other things done, not just to get their feet checked. Next slide. Some of the discussions we've had are to do a PDSA for the baby-friendly project that we have here, how to improve our nursing care plans, and how to improve the process for that. And we also had reflective discussions on what each of us took away after we had the land discussions. Next slide.
Looks like that's the last one.
Oh, okay.
So thank you. I'll open it up to the floor. If anybody has thoughts or comments, or if you want to add to chat, please go ahead and do so. Any comments?
Well, hi, this is Jade Purdue with CMS again, and I was just writing into the chat. You just made my heart sing. What you said about placing patient outcomes first when making decisions. I mean, I think that is really the core of a healthcare leader. And I was so excited to hear about the diabetic shoe program, and I'd love to learn more about that. So that's really incredible. Thank you so much for all the work you're doing.
Thank you.
I would just add, in this time with the major challenges that need to be addressed, not only in the Indian Health Service, but in many healthcare systems and other parts of the organization, actually the recognition that probably we've gotten into a lot of difficulty in healthcare because we've developed a competitive rather than a collaborative system centered around hospital-focused and provider-friendly delivery systems. And indeed, if we are going to move forward and really embrace the value equation, then we have to make this patient-centric. So I believe that doing that in everything we do, as you have done, will continue to foster movement in the right direction. If the patients are better, the journey we've taken, whether it is filled with a lot of conflict management or getting rid of the unjust culture, will all be worth it. Thank you for your great work.
Thank you for the comments. Continue to put those in chat, and thank you, Belcourt. I'm going to turn it over to Blackfeet up next. So if you want to unmute yourself and go ahead.
Good morning.
Morning. We can hear you great.
Okay. This is Christine Powell. I am presenting on behalf of the Blackfeet Service Unit. We are going to go a little bit off. We're not really going to follow our slide. We would like to just share some of our good experiences with the PATH and some of our takeaways from the LAN. We have 12,000 people registered at our facility. 7,000 utilize the facility. We're a licensed 24-bed facility. We offer 24-hour emergency services, surgical, labor and delivery, and a variety of specialty care are a few areas that we'd like to mention. We're currently working toward home health care model, working toward Joint Commission accreditation, and some of the PATH has assisted our facility in various areas, including quality improvement, support for our facility in building capacity and leadership development. Dr. Royer came and helped us build our roadmap to excellence by assessment and formulation. He assessed our facility processes and helped us identify strengths and weaknesses. 7 areas of priority are culture, leadership, HR, quality, service of healthcare quality, admin, operation and process, and government processes. November 1st, we went over the accountability matrix, and we had some takeaways from that and actually implemented some of the supervisors that participated in the webinar that day went back to their respective departments, and Caitlin assisted us in plugging in and actually using the accountability matrix. So one of the areas that we used it was improving our communication when hiring for regular full-time positions and contracts. So we kind of had a little breakdown in communication between in our facility between just bringing people on. So we just really implemented and used the matrix to identify our weaknesses, our strengths, identified the key people, and the processes and procedures and methods and tools to improve those processes. So with that, that's all I have.
Thank you, Christine. I will ask, because I want to make sure that we have our time for the rest of our facilities to present. Keep those comments and feedback coming. Put those into chat. We will make that available to folks after the session, so please go ahead and put any questions, comments into chat directly. But I will ask Cass Lake, if you are ready to present, we are ready for you.
Good afternoon, everyone. My name is Joanna. I'm one of the pharmacists at Cass Lake Indian Health Service, and on the screen you can see our leadership team, or part of the leadership team that participated in the LAN meeting. On the picture on the top left there, real quick, is our recently remodeled clinic, which we're really proud of. Well, the other 2 photos as well. We worked really hard to build this space, and we're really proud of it. And our patients, I think, are pretty proud of it too. Next slide, please. Our leadership, discussing the LAN takeaways, the messages that resonated with our group, we realized that we are all very passionate for our work here, and we thought that it was really important to engage our employees, and so that's what we focused our takeaways on. We feel that engaged employees are very effective employees, and we worked on how to build will and celebrate our successes. It seems like a lot of times we talk about those near misses or misses, and we don't spend enough time on those successes. We also talked about transparency in our organization and have been working very hard to improve that. We developed a new orientation process to provide better information for our new staff coming in, and hopefully we'll give them a better impression of our organization. And we implemented a cultural competency, or I shouldn't say implemented, we reestablished that and invited local cultural advisors into our facility to provide the staff with education about our community. And we hope to expand that with additional people from our community, and have actually identified someone who will come in and work with us. We are also hoping to measure that impact by incorporating those community values within our organization. And the overall consensus of the group is that the LAN activities were very valuable, and we really appreciate our path partner, and we think she rocks.
Thanks, Carrie.
Great, thank you, Joanna. I appreciate that very much. Again, I encourage folks, go ahead and put it write in chat any of your comments. And I think that's Carrie Zimmerman is our PATH partner that has been supporting that folks are referencing. So I will turn it over to Crow Northern Cheyenne next. If you want to unmute yourselves and get ready to present, please put comments into chat as we're going. Crow Northern Cheyenne.
Well, good afternoon, everybody. Hello to my former colleagues at PIMC and Rosebud Hospital. Good to hear from you. Yes, at the Crow Northern Cheyenne, if you stay on this first slide, it's kind of hard to tell when you see those cross beams at the front, but that's really a symbolic of the Sundance. As you go in, this building faces the east, so it's a place of healing. And then you see the diamond shape, the red and the blue and the white and the yellow. That's the symbols of the Northern Cheyenne tribe. So we take care of both Crow and Northern Cheyenne, as well as other Alaska Natives and other tribes that come in for direct care services. We are a 25-bed critical access hospital. And what we've gotten out of the PATH initiative here is working with Mary Erickson and her team as our QIO for Mountain Pacific, as well as the HIN group. But the biggest thing I think is involving our supervisors and other staff who want to join. We've opened it up with the IHI school. We stressed that to everybody who wants to get involved. And I think it was the lessons I learned during my detail out to the Great Plains to help the Rosebud when they were dealing with CMS. And at that time, we had leaders from CMS come out, and I really thanked them at that time for providing this training that they discussed that we're now doing here at our facility in the Billings area, because I think quality care has been overlooked in IHS for so many years. And my experience coming from private sector, I kept saying one day there's going to be a hybridization of federal and private sector philosophies, and that's exactly where we are today. So I'm really grateful for the opportunities that the things we're learning. You can go to the next slide. So besides the team you see on the participants, we really have a lot of supervisors. We have about 29 supervisors that are actively involved in learning about different areas as we brought on the Joint Commission, the AMP program, as we're developing facility-wide assessments of where we are right now. We've developed a 90-day plan strategy to go from CMS certification to the Joint Commission accreditation process. So we're really being aggressive about that and really focusing on the quality initiatives. And as I said, the things that I saw in the Great Plains that they were struggling with, I wanted to make sure our facilities out here were aware of those problems. So we were able to share that knowledge of the struggles, and as far as quality measures that CMS surveyors were looking at. So it was a very positive experience for me to bring that back to the Crow Northern Cheyenne Hospital. The other ideas that we've had is the quality councils and subcommittees that were developed over the last 6 to 8 months, and also having the phase 1, phase 2 strategy plans for our strategic plan initiatives, and allowing staff to put comments in as for some of the struggles, the negative things that you have to face, the personality conflicts, the leadership increase in our knowledge to be able to be a leader. All these things kind of came out of the really our leadership networking that we're doing now. And I'm just really excited that we are starting to understand the importance of quality in healthcare in federal facilities. And it's not just tracking numbers and submitting them up to headquarters. It's about the people. And that's really what we are looking to do with a recent modernization project, is making our facility, our hospital, more patient-centered, so that it's not this sterile environment where nobody feels like you want to come in to see the doctor. You want to have a team. The IPC model, we're developing that further, and really just taking all these patient-centered ideas more serious as we move forward into 2018 and 2020 in our strategic planning. And we want to thank Dr. Royer as well. I think his directness to our staff and supervisors, really, they were the ones pushing me, like, we've got to keep moving forward with what he's bringing out, because that's the honest truth. And I think that's what we all need to focus on, is the honest truth of where we really are and what we need to do for the communities we serve. I think the biggest thing when you look on the slide is the leadership competencies. Leading change is difficult, and we all need to improve on what we know and what works best, because healthcare systems and models change, and leaders need to change with those. So thank you again for the Mountain Pacific and Dr. Royer and their work to getting us on the right track. I think that's all I have.
Thank you, Darren, very much. And I'm just reading through all of the comments in chat. Please keep them going. I will turn it over to Red Lake for their presentation at this time. So Red Lake, you're up.
Hi, this is Carrie, and I'm actually speaking on behalf of Red Lake because they are in a governing board meeting. So I think we're all having a lot more fun here than they are having there right now. But I am speaking today on behalf of Rebecca Finday and Angela Tucker. So Rebecca is their new quality manager, and Angela Tucker is their new safety officer and infection control person there. And you can flip to it. Thank you, Dion. Both of these women are new to their roles, new leaders, and I think that this, I'm not going to read through their words word for word, but I can tell that this was really helpful for them in learning the leadership competency, helping them with some of the questions or struggles that they are having themselves, and then also being part of a new team. And then the other part that I think that really stood out for them is the networking. So hearing from other facilities, hearing from other people in leadership roles, just like they are in, and also from our subject matter experts too. I think that piece was just really invaluable. Specifically, things that they have started since participating in the LAN is they're looking at their web-student process. So I know that was talked about with one of the other facilities too. So we should probably link you guys back together. And then also, again, I think this was talked about in another facility or two, but just the communication and the teamwork in and amongst the leadership team, and then how we communicate with our frontline staff.
Great. Thank you so much, Carrie. I am going to encourage folks, questions, comments, feedback right into chat. And next up, we have 4E8, Standing Rock Service Unit. If you're ready, the floor is yours.
Yep, this is Darren Schaubert. Can you hear me?
Yes.
Okay. I'm Darren Schaubert. I'm the clinical dietitian at Standing Rock Hospital. I'm going to be speaking on behalf of Wayne Mouth, who was our quality team person in radiology. He had done some reports. I'll also talk about some of my own projects. We work out of the Standing Rock Hospital. It's in North and South Dakota, covering patients in 5 clinics across that region. And we learned a lot from the project here also, in that a lot of it was how to build more cooperation amongst staff when it comes to quality projects, how to build more people into the project by helping them to understand that they are a part of patient care, even though they're cooks or whatever the case might be. And it really helps when they see those things, because it helps them in their daily work, because they understand how things are linking to other parts of the hospital. A lot of times people don't understand what a part they have in the whole process. And in radiology, we focused on discrepancies in photos of radiology. We take about 463 exams a month, and we usually saw about 13 discrepancies in some of those pictures that were taken. And by doing weekly meetings with staff, looking over the problems, talking amongst the staff on what did you do to take this shot, or when we do these types of things, can you do them better? It really improved patients' understanding and flow of everything. And with that, we saw a drop in the number of repeats needed from 13 down to 7, which is about a 50% drop in the rate of errors in the photography that was done. And you'll see on the next slide here. We also did a lot of work with having the staff involved in the process. We do bi-monthly meetings with Denise Clipful, our quality improvement director, and such. And we've been involved in the programs that we've had here too, which have been very helpful. It makes you look at things a little bit differently and helped us to understand how to work together on a different level so that it's more fun for everybody. With the cooks, we focused on dietitian referrals by physicians. And what we did is we brought that into the quality meetings and talked about it, and looked at the numbers and rates. And we brought those up to almost 75 referrals a month with that process. And with that, I'm having the cooks actually calling patients to bring them back in for visits and such then, so they understand why it's so important for them to be doing what they do so that the patients have a chance to come in, and how important it is for those patients to be seen. We had one patient that dropped 264 pounds in just 7 months with things that we did, and many others that aren't on insulin at all anymore. And so by taking that back with staff and talking about it after the fact, people get really excited about their role and their involvement in the quality process. So it's been really a lot of fun for all of us. It decreased a lot of anger and things that you'll see, like in repeating the radiology exams. A lot of times people get really anxious or mad if they don't like what they're seeing and such. And by talking about it amongst staff, it brought the anxiety levels way down and improved the physician's happiness. They can talk directly with the physicians now, and they are very positive about it now, where before it was like you against me type thing. And that's always really nice to see. I guess that's the majority of what we had for our project that I can talk about today.
Great, thank you. I will turn us right over to Rosebud. I know we're close to the end of our time, but we'll go through Rosebud and then we'll close out for today. So Rosebud, you're up.
Okay, so this is John Schuchart. I'm the acting CEO at Rosebud. As it was talked to, a lot of people probably know that we've had a lot of issues with CMS, particularly in our emergency departments. And when I got here, I've been redetailed as the acting CEO. And so when I got here, we had those two challenges, completing the SIA, which we successfully did. And there's a lot of folks on this call that were had a large contribution to that success. So thank you all for that, for what you've done here. And then the other was, this was unknown to me, but we had a contract for our coding and billing at the facility in the area, and the facility was highly dependent on that contract. And so that was going to end September 30th, and we had to figure out how we were going to absorb all the coding and billing at the facility. I think I'm going to skip that for a little bit, but I really want to talk about, and there's the facility, is I wasn't able to be on the entire PATH call, but I listened to the recorded session, and Dr. Aurora, there was a conversation about mediocrity and how it's unacceptable and how it also oftentimes will extinguish people who are trying to affect positive change. And so what we see here is our greatest opportunity for improvement and success resides with our middle managers, our department supervisors. Too often we have people that are placed in that position. They're the last person standing, so you're it, or they have little supervisory experience. And most often, so similar to Crown Point, they're too busy doing the work to really engage doing full-time supervision and department managing. They don't seem to really understand our HR process very well. I struggle with that myself. How to write an effective PD, an effective PMAP, what tools that they can use in the HR process. If they have to use, like a letter of expectation, that's okay to do if you need to. They struggle with the contracting process, and developing accurate policies. Sometimes we work on perceived policies and it's not actually what we should be doing, or it's not our actual policy. And also middle managers sometimes don't really know what metrics to measure. And so they don't know how to gather the data, they don't know how to analyze it. And what it really results in is a highly subjective method of supervising. And so, that's something that we see. So I'll talk a little bit in a minute about monthly productivity stats. And then they also struggle doing project management. Oftentimes their department heads are tasked with an assignment, some project that we need to get off the ground and get going. And the meetings end up being more narrative versus actual tasks completed, tasks need to be done, those type of conversations. So we've engaged using the PATH recorded sessions. We brought in the department heads. We've listened to last two, and we've had conversations afterwards, and we look forward to continuing this process. The past folks from South Dakota have been out a couple of times, and they're helping us with a outpatient access to care project, which has been very fruitful. We appreciate their efforts. The monthly productivity stats, we work with our department supervisors, and this is really in its infancy. We probably address maybe 65% of the departments in creating these, what we're actually going to measure. And we really want to get all personnel. So, it really accomplishes three things. We get a baseline data to measure productivity going forward, trying to maximize our under-resourced resources. Everyone's job is very important to the mission, and we need to make sure that they are contributing to the mission on a daily basis. It provides those supervisors actually a means to assess their employees objectively, and it's not the whole picture of how you're going to assess your employee, but it gives them a metric that they can stand on also. It also provides the C-suite a means to analyze each department's needs, staffing needs, equipment needs, training needs, and to a lesser degree, the supervisor's performance. And oddly enough, the Hawthorne effect is well in Rosebud. If you observe something, it usually results in improvements, and that's what happened in the revenue cycle. So the revenue cycle, we had 7 weeks to absorb this and figure out what we were going to do. We started having daily business or revenue cycle coffee meetings 5 days a week. We talk about the coding, the billing. We brought in patient registration. We sometimes talked about pharmacy point of sale. We started those conversations. And I'll be honest with you, the first 3 weeks, I was pretty nervous because we were still having difficult conversations and we weren't having appropriate conversations. And so we finally got to the point that, we got beyond that initial, I think everybody was pretty anxious about this. We got beyond that anxiety stage and we started actually having meaningful conversations. And we started to reach, some goals, and we identified things that needed to be done. We had more assets. We needed an additional asset in the business office. We needed an additional asset in the HIM to code. We actually identified RPMS issues with billing dental claims that had been laying dormant for over a year. We got that resolved with headquarters very quickly. Something I'm a pharmacist, so I don't really know much about the business office, but we didn't really know what were useful reports, and now we do. We actually literally track each coder and each biller, what they're billing on a daily basis to see how they're doing, and if there's issues, we talk about them. It's not like, okay, what happened here? It's like, okay, what's going on? How can we support you to make this better? And it really comes down to communication. If you get the right conversations started to occur, and we started making some serious progress. So I'm happy to report that 9 weeks in post absorbing the billing and the coding, we're actually exceeding the mean collections from FY17 on current year. So it's been very successful, and it was very satisfying to get to this point. And that's all I have.
Thank you, and congratulations. Thank you. And congratulations to everyone that has been presenting. I know we're at the end of our time. I won't keep folks, but we will keep the chat and the meeting open. If folks have any last comments or you'd like to have your feedback or words heard and captured, we'll keep the chat open so that you can do so even a few minutes after the meeting. Just looking ahead to 2018, we will capture the momentum of 2017. We've received lots of feedback from many of our participants, and we're working to incorporate that. You can see some of the changes right on the screen. Jade mentioned some as well in her opening. I will follow up with an email to help encapsulate all of that and link folks to the resources, the recordings, and the other information. So thank you so much for joining us and taking another 90+ minutes out of your day. Amazing success stories. Keep up the great work. We will stay on the line again, if you have any additional feedback, but otherwise keep an eye out for an email which will give you information about 2018. Thank you, thank you, thank you. Have a great, great day. Bye-bye, guys.